Next, I would like to invite Dr. VEENA. She is consultant cornea surgeon at Chaitanya Eye Hospital, Trivandrum. She'll be talking on emergencies that you commonly see in cornea.
Okay, good evening to one and all. So let's go into the emergencies in cornea and ocular surface as such. So corneal emergencies are commonly encountered ocular emergencies that could be a potential cause of visual and structural deprivation. So it's an interesting clinical picture where you can see a smiling face. So it's a atypical microbial ulcer of the cornea. So corneal abrasions, they constitute 10% of ocular emergencies, causes being mechanical trauma, contact lens related, foreign body, chemical or flash burns. Management is obviously medical, and you can use a bandage contact lens, but it's better to defer patching because that can dampen the healing process as such. Corneal foreign bodies are usually comprised of sand, dust, as in this clinical picture you can see a metallic foreign body in the peripheral cornea, and especially seen in activities that pose more risk, including grinding, hammering, drilling and welding, especially in the lack of protective eyewear. So this is another clinical case. It's a 45-year-old male patient. You can see a pigmentation at 4 o'clock of the cornea. So on magnified examination, you can see that there is a foreign body right in the center of that pigmented area, which is there through and through into the cornea. So on doing a gonio, we could see that the foreign body was there in the angle, slightly pinching onto the iris, which is there behind. So on dilated examination, we can see a pigmented cataract. So this is a case of siderosis bulbi. Because the foreign body was there for 2 years. So the trauma happened 2 years back, and because of the long-standing foreign body right there in the cornea, the patient went into such a scenario. So all metallic foreign bodies, regardless of the depth, are to be removed. Smaller restrings can be left behind, but larger restrings and especially in the central cornea are to be removed promptly. Next, going on to another case where you can see patterned corneal abrasions in the inferior cornea, inferior 1/3 of the cornea. So on examining the lower eyelid, we could see a hair-like structure which is there in the tarsal conjunctiva. And on further examination, we could see a granuloma also there. So this is a case of caterpillar hair in the eye, which is caused ophthalmia nodosa. So such foreign bodies are to be removed promptly, and if caterpillar hairs are there on the cornea, it could be very difficult to remove. So you can give the patient topical steroids and try removing them on further follow-up visits. Next, another common clinical case in cornea that usually we come across is recurrent corneal erosions. Especially in patients, these patients usually come up with preceding history of trauma. Whenever there is no history of trauma, you should think about corneal dystrophies and other corneal ocular surface diseases. Management is always medical in terms of lubricants, and if they fail for 3 to 4 months, we can go ahead with removing a mechanical removal of epithelium using alcohol delamination, and then place a BCL over it. Next is corneal laceration and penetrating injuries. According to Beaver Dam Eye Study, 20% of the population, they suffer from an ocular trauma in their lifetime. It could be either full thickness or partial thickness. It could be penetrating or perforating depending on the presence of entry and exit wounds. So first, whenever a patient comes to you, always consider life before eye, consider systemic stabilization, and then get into the globe repair as such. So this is a foreign body which has gone through and through into the cornea. So never attempt to remove such foreign bodies in slit lamps or in your OPs. Always take the patient to OR. Globe perforation, the management protocol is immediate eye patching and shielding, tetanus immunization, systemic antibiotics, and then take up the patient for surgical repair. So goal of perforation repair will be to ensure a watertight globe, to maintain the globe integrity and to normalize the intraocular pressure, remove contaminated and non-viable tissue and foreign body of course, and reposit the viable tissue to restore the original anatomy, avoid iatrogenic damage, restoring visual function if possible. So that should be kept the last. Surgical principles, 9-0 nylon or 10-0 nylon can be used for closing limbus and cornea. Vical sutures are ideal for scleral and conjunctival repair. So corneal sutures are to be taken at 90 to 95% depth through stroma by using 3 throws. First perpendicular, second parallel, and third perpendicular again. Always start from the limbus to allow precise apposition of the tear edges. Conservative management using a bandage contact lens can be considered in small tracts less than 2 mm, self-sealed, especially when pressure seals is negative. There is no iris prolapse and there are no signs of infection. In vertical lacerations, entry and exit wounds are to be equidistant from the laceration, while in a shelf laceration, only on the posterior surface they need to be equidistant. The concept of compression zone can be used to enumerate the number of sutures which are required to close the laceration. Rose-Hayes technique shows that the central in this technique the central bites are to be shorter and the peripheral bites are to be longer in order to preserve the normal spherical contour of the cornea. In angular corneal wounds, always start suturing from the angle and not towards. In triradiate or stellate corneal lacerations, you can use Akin's method, wherein it's considered as a multiple flap test and you have to close each flap and then suture to each other, or you can use a purse string suture to close it as a whole. Prolapsed iris, whether to repose it or not to repose it. Preserve as much as uveal tissue as possible within the 24 to 36 hours maximal safe period. And if you feel that the prolapsed iris is necrotic, do not repose it, abscise it, and do not excise it. Then this is another clinical case scenario. This is a 40-year-old male patient who had come with this clinical picture. We can see that the luster of the cornea has gone with a perilimbal ischemia almost 360 degrees. This is another case, 15-year-old girl, post firecracker injury, which is you can see a central stromal edema there. So if you are not managing these cases promptly, they can lead to a clinical scenario like this in the long term. So we are discussing about chemical injuries. So this is the only eye emergency where you cannot afford to waste time even for documenting or taking history. So immediately you have to give irrigation, copious irrigation with whatever neutral solution is available in hand after checking pH of course, and you have to double over the lid and then give wash. Check pH at the end of every 5 minutes. At least for 15 to 30 minutes you are supposed to give irrigation, and then once that is done you can clinically examine the patient and grade the chemical injury as per Duar's classification. Then acute phase management is medical with the help of antibiotics, lubricants, steroids and cycloplegics. Surgical treatment can be given in the form of amniotic membrane transplantation and telonplasty if the epithelial involvement is extensive with an extensive perilimbal ischemia beyond grade 3 in Duar's classification. Next, coming on to corneal ulcers. These are the various clinical presentations that you can come across in your OPs. So depending upon the clinical presentation, you can differentiate the etiology. As in the first picture, you can see a dendritic and a geographical pattern of the epithelial defect, which is mostly pointing towards a viral ulcer. While in the second one, you can see a dry looking ulcer with satellite lesions and a fixed hypopion pointing towards a fungal ulcer. Whereas in the third one, it's a patient who is a BCL user who has come with a fixed, well demarcated infiltrate and a mobile hypopion pointing towards a bacterial ulcer, in this case to be specific Pseudomonas. And in the last picture you can see a well defined epithelial defect, clean one for that matter. So it's a neurotrophic ulcer in a patient with lag of thalamus. So treatment protocol, document the findings, come to a clinical diagnosis, send sample for gram staining KOH culture, usually corneal scrapings, and then start the patient on empirical therapy. If the patient is doing good with it, continue the same. If there is no response, modify the medications according to culture sensitivity. Even after that, for 48 to 72 hours, if the patient is not responding to your treatment, then you have to repeat the scraping, or for the last you can consider corneal biopsy. Perforated ulcers less than 3 millimeters, you can consider BCL glue. For then more than 3 millimeters, in the center you have to go ahead with a therapeutic keratoplasty. In the periphery you can do with a patch graft. So this is another interesting case of peripheral ulcerative keratitis, where you can see this is a 45-year-old female patient who was stable initially. It's a case of Moran's ulcer, and then she came up with a perforation at 12 to 2 o'clock, which was later on patched with a scleral patch graft. And then you can see that subsequent to that, she again had a thinning at 3 o'clock. So finally, we had to do a repatch graft with a multi-layered AMT. So currently, the patient is stable with systemic immunosuppressants. So that's it. Thank you.
Thank you, Dr. VEENA. That was an interesting and nicely documented